Good morning, everybody. Welcome to the webinar. We're going to get kicked off here in a minute. Just wanted to introduce ourselves in the webinar series. Thank you for being here. This is the first in a 6-part series around performance improvement for rural hospitals. We're excited to kick off today with session 1, which will be led by Eric Schell. We're looking forward to kicking off this series, and we will just have a few housekeeping items to attend to as we go through the presentation. You will see a Q&A feature at the bottom of your screen, and this will allow you to ask questions throughout the presentation. We definitely want to encourage participation for all those who are on today. And with that, I'm going to turn it over to Eric Schell, who leads our performance improvement practice here at Stroudwater. And he will be jumping into this webinar, which is really the keynote session in the 6-part webinar series. So Eric, I'll turn it over to you and look forward to hearing from you.
Great. Thanks for the short introduction here, and appreciate all you guys joining in this morning to hear about financial and operational improvement in small rural hospitals. This is a kind of an important time to take this matter seriously, just given the potential impacts of OB3 to rural hospitals and the uncertainty that was created. And so we thought it was a really important time to have this discussion. So let me I've got to just click a few things. Can I just ask, is it showing me or is it showing the slide deck? Wade? I'm okay. So yeah, that's me, Eric. And as Wade said, over the last 28 years, I've had the opportunity to travel around rural America, helping somewhere between 350 and 400 rural hospitals. And last spring, we wanted to sit down and say, okay, when we look at improvement in rural hospitals, where does the majority of that improvement come from? And so we ended up pulling from a sample of about 30 hospitals that we were engaged in through the National Rural Health Association / USDA Performance Improvement Program. And what we found is that on average, and this is the median, was about we were able to help improve bottom line by about 1.7 million. And it wasn't in areas where a lot of hospitals think consultants go after. And where I'm referring to now is most folks, when they see consultants walking in the door with their ties and shiny shoes, immediately are concerned that staffing reductions are the #1 opportunity. And we fundamentally feel differently about that. We are looking for outmigration and inpatient services, where a bulk of the improvement in the hospitals has come from. Revenue cycle improvement, service line growth, swing bed program is often an opportunity. And we'll talk about that in the bowels of this report. 340B program is often sub-optimized. Cost report opportunities, especially in the critical access hospitals and other. But there hasn't been one recommendation in the last 30 hospitals that we had worked with under this USDA NRHA project that had staffing as a reduction. And so I want to talk about why we think this way and why we think that there's a significant opportunity for rural hospitals. Oh, I did want to say this, that I know this meeting is scheduled for 2 hours, but if any of you can listen to an accountant speak for 2 hours, I put you up on a pedestal. We're gonna see if we can't get through this in about 90 minutes, which even still is a stretch, but hopefully this will be well worth the 90 minutes that you spend in this presentation. So as we—
And Eric, quick question. I'm getting that we can't see the presentation slides at the moment. So I'm wondering if we just need to pause and make sure we can
let me see what's going on there. Yeah, if they're not showing, that's probably not good. Let me know when they come back on.
Yes, I'll let you know.
Boy. Not sure. Let me exit out and then come back in with the presentation.
Perfect.
Share. All right, how's that look?
Much
Yep,
better.
if we swap displays, I think oh, there we go. Okay, we're good. We're good.
Okay.
Thank you.
Oh, that was really interesting. Never had that happen. As Wade introduced, let me jump back into into the presentation here. The This is a 6-part series where this first session, this 90-minute session this morning, is going to set the stage for several other mini presentations. So this is the first part is when, essentially when Stroudwater goes in to look at rural hospital operations. Essentially, this is everything that we look for to seek out improvement, and starting with very high level and then drilling down into the specifics. That's going to be this first overview. And following that, there will be a presentation by our colleague John Downs, looking at outmigration and how we can address outmigration, but first understanding what it looks like. Wade is then going to have a follow-up presentation on the cost report. There will be a swing bed boot camp that our clinical team will put on. We'll have specifics around a 340B program, and then we'll have the 6th presentation. It will be around the deep dive into revenue cycle. So again, this is all, I think, the timing is right for this type of boot camp, given the uncertainty that's been created in rural with the passage of the OB3. So the last couple slides in this presentation will show the dates and when these presentations will be held. So to kick this off, these are the areas that we want to touch on. The first is this culture, abundance, accountability, economic philosophy. I'm going to talk about the 3 keys to success within what we see as organizations that have gone from struggling to substantial improvement, and the 3 keys to substantial improvement. And many of you have heard me talk about that in the past. So we're going to touch on them. We'll talk about strategy. Strategy is something that's become more challenged lately when a payment system is no longer static. And we'll talk about why that is. Gosh darn, this keeps jumping around on me. We'll then kind of get into departments and we'll dive down into inpatient services, clinical services, emergency services, and touch on a number of these other areas. So this is why it's a 90-minute presentation. We're going to touch on a whole lot today. My goal for you is to take away, jot down. Let's just have everyone challenged with writing 5 things from this presentation that you can take back and take a look at or do something differently. So as we kick off, a high-level overview. When we see rural hospitals struggle and then something changes and their performance kind of accelerates and they start performing well, there are 3 key areas that we look at and for this improvement. Much of which, when we are looking, it's this, as we write these strategic financial operational assessments, these 3 characteristics are repeated over and over and over again in the body of these reports. And we'll touch on those as we drill down deeper into the clinical departments and opportunities for improvement. But the first key to success within rural hospitals, number 1, is an abundance mindset or an infinite game mindset. The abundance mindset was coined by Stephen Covey. He compares and contrasts abundance mindset and scarcity mindset. And where a scarcity mindset, there's a pie of success in the world. And if Wade is successful, he's taken from my pie. And in a scarcity-based person will seek to cut Wade out of decision making. He'll take credit for Wade's actions. He or she will, hoard information, not share meetings, but it's all around locking down their own success through blocking others. An abundance mindset says if Wade's successful, the pie grew for everybody, meaning that there's more for all. And often what I've found in travels is that in rural hospitals, often scarcity rises to the top because scarcity is about oneself versus abundance. It's out for all others, which leaves a blind spot on the back of abundance people. And so abundance, is I would say the number one key to success in rural hospitals. If anyone wants additional information, there was a webinar, a panel discussion we did a couple weeks ago where I had three very abundant-minded speakers as panelists. Kevin Durande from Iowa, CEO of a hospital there, Benjamin Anderson from South Central Kansas, and then Mary Ellen Pratt from Louisiana, all gave an incredible presentation around their thinking around abundance and how they see abundance play out. Infinite game mindset. This was a concept that Simon Sinek developed several years back in his book, The Infinite Game, where he talks about the fact that in healthcare or in any business, we play in an infinite game with no, versus a finite game, which like a football game. There's four quarters, there's rules, we know the team we're playing against, and there's a winner and loser. Where an infinite game in healthcare, we don't know all our competition. We don't know the rules of the game. People can change the rules of the game. But in that type of environment, the goal is not winning or losing. It's to perpetuate a mission that is beyond ourselves or our organizations. And both of these, I think, as this, the different sides of the same coin, having this type of leadership at the top is absolutely critical. The next most important key to success is understanding fundamental economics of what drives profit within our rural hospitals, or in some cases, drives reduced losses in our rural hospitals. And it's this idea around contribution margin, where we've got to think of our organizations of thousands and thousands of mini contribution margins. So what's a contribution margin? If it's the key to success, what is it? Well, first of all, a contribution margin is defined as revenue less the variable cost of producing that unit of revenue. If we think about that as an inpatient admission, for example, if we admit a patient today, we generate $2,500 today in revenue. That's easy to define, but the expense is much harder to define because our accounting systems are not going to give us this answer. But if we close our eyes for a second, but please don't do it for too long or we're going to lose you. If we close our eyes and think about what are the true variable costs of the admission that we had this afternoon at 2 o'clock, it becomes pharmaceuticals, reagents, film, food, kind of very little. And whereas the fixed or step fixed costs are a significant majority. What this is saying is that contribution margin is significant in rural hospitals when the variable costs are small. Right? Revenue less variable costs, that's a big number to cover all the step fixed costs of our organization. Earlier this summer, the University of Iowa came up with a study where they looked at, now I'll sum all of these words down into, just I'll point to a couple numbers here. What they looked at is they evaluated hospital performance between 2011 and 2020 for almost 5,000 hospitals over this time period. And what they looked at is in this chart I'm going to point to, so you pay attention, they compared the metropolitan hospitals to micropolitan hospitals to non-adjacent large metro or with town of 2,500 plus, and then the smallest. So think of it as large, medium, small. And this is the count of hospitals. And what they found was this ratio right here was the median fixed costs as a percent of total costs within an organization. And what they saw was that the smaller the hospital, the higher median fixed cost was for providing a good or service. What that tells us from looking at this is on average, for the smallest of rural hospitals, that contribution margin from incremental admissions or incremental emergency room visits or incremental lab tests is almost 93 cents on the dollar. Play that out in terms of how does that impact the way I think and about my operations? It puts an extreme value on incremental volume when you can dilute more fixed costs over higher units of service and generate this contribution margin. When you combine the first key to success, an abundance mindset, with this knowledge of fundamental economics and contribution margin, it puts an absolute premium on growth and incremental volume growth to dilute our fixed costs and create contribution margin. So I just think that this study was just so well done, and it fell on the heels of a study that University of Iowa School of Public Health published 2 years ago that started this conversation. The last key to success, before we start drilling down into the specifics, is a measurement culture. Organizational theory says that when essentially there's a three-legged stool: decision rights and where we set decision rights, performance measurement, and compensation. And the theory says that in organizations where there is very site-specific information that we have to use to make decisions that advance the cause of an organization, and that site-specific information is down in the bowels, then we have to push decision-making down rather than centralizing it all in the CEO's office. To the extent, and I would argue, I wouldn't even argue, I mean, it's known that for in our hospital business, so much of decision-making has to be made down right in front of the patient where we're making decisions. Decision-making has to be pushed down. And if that's the case, we have to tweak the other two legs of the stool. Let's just start with compensation, and then we're going to end with performance measurement. To the extent that we are going to push decision-making down, then we have to tweak compensation. We have to recognize and reward performance that aligns with the organizational goals, and recognize performers that kind of do that more than those that don't. And so that what that essentially is requiring is some type of a compensation system tied to performance. And so pushing decision making down, compensation, we really don't want to have it a static compensation model. We want to create opportunities for advancement within our organization with compensation. And the third leg of the stool then is performance measurement. If we're pushing decision making down, if we're rewarding extraordinary performance aligned with organizational goals, we've got to create a measurement system. And it's a measurement system that does two things. One, it provides information to the frontline managers to see the impact of decisions that they're making. And the second piece is, because we have pushed decision making down, we have to have higher level of centralized information, performance measurement, so that the leadership can assess the performance that's going on down in the bowels of the organization. And so I would suggest in healthcare, the imperative to drive decision making to the front lines requires a higher level of performance measurement throughout the organization, and then a compensation system that rewards. So these three keys to success, and I have case study after case study after case study of rural hospitals that have lacked these three elements, that have implemented these three elements, and the extraordinary performance gains that they have had. Are there any questions? You can type your questions into the chat box if anyone's got any thoughts around this. All right. Hearing none. What I want to start off with, this is where we start to drill down into essentially when Wade, myself, the Stroudwater team goes to work with hospitals. These are the areas that we like to see. We like to see these types of things being done. The first is organizational strategy. And several years ago, Stroudwater came up with this, what we call this transition framework, recognizing that payment, for years, for 50 years in healthcare, the payment system remained static. It was fee for sick care, straight fee for sick care. And the functional imperatives of this fee for sick care payment required us to do three things. It required us to maximize price that we got paid for sick care. It it the second imperative was it maximize sick care volume, and the third imperative was to minimize expense. And any organization operating either in conjunction with another or independently, to the extent that they could maximize those three functional imperatives, would be successful in the fee for sick care payment system. And so the form that evolved out of those functional imperatives was essentially independent organizations competing for market share, right? More sick care volume. Now the payment system, whether it's over the next 10 years, is moving slowly, but there's a new type of payment system that's creeping into our healthcare world, and that is a transition towards a population. And the functional imperatives of a population-based payment system. Wade's worth $10,000, I'm worth $10,000 to a healthcare system. Now the functional imperatives become very different. They become aggregating lives to diversify insurance risk, aggregating resources so the healthcare system of the future can take care of Wade and my health and sick care needs, and the incentives change. So the functional imperatives fundamentally change. What we do fundamentally changes in that payment system, and how we look to accomplish those imperatives. Organizations will have to come together. And so what we do and how we look change as the payment system evolves. So what we did back several years ago, working with some critical access hospitals here in the Northeast, we said, okay, going across the x-axis here is a payment system that is evolving very slowly. It's inching forward from fee for service to phase one is kind of think of that as fee for service with tie-ins to quality and utilization. It's the world we live in today. To phase two, which is kind of alternative payment models, ACOs, built on a fee for service infrastructure. To now this next is alternative payment models built on an alternative payment model infrastructure. And finally, we believe that in the end, after we've failed at everything else, the large health systems will have will essentially merge the insurance and provider functions under one to reduce and eliminate that frictional cost that we see today going on between the insurance companies that want to cut services and hospital incentives that want to grow services. And so think of this as a payment system that's inching along towards something different over time. Put 2035 out here. But today is here. Put this at 2028. But if payment affects everything that we do, i.e. the functional imperatives, and how we look in delivering it, then payment and its transition has to become part of organizational strategy. And so what we did is we said, okay, if payment is going to evolve, there's three things that we have to look at and address. The first is the delivery system, the sick care model that we live in today. And we defined three initiatives that we have to address to fundamentally transform and position our sick care model for the future. We have to create a healthcare system. We still are fundamentally organized around a sick care or sick care delivery system because that's what's paid for right now. The problem with this is in this first phase where 90% of payment is still tied to sick care, we still get excited for snowstorms where people are going to fall and break their hip. So we got to create healthcare very slowly in this world. So in this first phase of payment, think of this as crawl, walk, run, sprint. And then finally, if we're going to create a healthcare system, if we're going to optimize and transform our sick care model, we better then create a change in payment and proactively pick up and move payment. And there's 3 initiatives that we identified to pick up and move payment. Each of the initiatives is tied to this orange bar. There should be an orange bar around this middle. We got to add that back in. These are strike points. When the initiative hits the orange bar down, here in phase initiative 1, down here in the payment system today, and then this right here, when the payment system is here, these are 3 initiatives that have to be implemented. So what are they? In phase 1, in transforming our delivery system, we got to improve our operation efficiencies. We have to focus on quality, patient engagement, and we've got to do that. The next phase is that we have to implement by the time the payment system evolves out to here is fundamentally aligned with primary care as the revenue drivers of a population-based system. So today we plan to implement in the future. The last is service network rationalization. What this is talking about is coming together with larger healthcare providers to take out big chunks of fixed costs, very few of which are in rural America. The big chunks of fixed costs when the payment system evolves are specialist technology bricks and mortar. So today I have a strategy, an implementation plan, and a strike point way out here. So these 3 initiatives and the timing of them become how we transform our sick care model. Around healthcare, we don't want to create too much health today. So let's just build the infrastructure, patient-centered medical homes, team-based care, data analytics, evidence-based protocols, all things that we can do today while we still are predominantly fee-for-service that maximize fee-for-service, but at the same time create a position on this new world. When we get out here, payer network contracting, hotspotting, value attribution, think crawl, walk, run, sprint. If we go all the way down in payment, this first initiative way down at the bottom in row 7 is at the strike point. And many of us have self-funded health plans, or if we're not self-funded, we're self-funded 1 year removed. What have we done around these plans, around our self-insured health plans to better understand claims, reduce outmigration, create plan design to encourage healthy behavior, discourage unhealthy behavior? What about all of the opportunities in the fee-for-sick care world that we live in to get paid for healthcare, annual wellness visits, chronic care management, healthy physicals? All of these are opportunities that we can get paid for healthcare today that many of us have not optimized. And then as we move up here, transitional payment laws, ACOs, those types of things, start thinking about how we want to participate. Right here, our only at-risk population to some degree is our self-funded health plan. As we move up here, we start taking more at risk through the ACOs or low risk population-based payment model. And then way up here, this strategy is full risk capitated plans. This goes hand in hand with your service area rationalization, coming together with larger organizations, in this case, not to dilute or just decrease fixed costs, but to aggregate lives to diversify insurance risk. But what we feel is that there's a couple important parts of this transition framework, i.e. as the basis of organizational strategy. One, essentially it creates this transition to population health payment. It puts it into bite-sized pieces. The second thing it does is everything that we do in column 1 here maximizes the heck out of the fee-for-service payment system and it creates a position on the next payment world. So it's a twofer. If the payment system never gets out here, if for some reason we just get stuck in our tracks, everything that we've done here continues to maximize the payment system that exists. We believe that when sick care, i.e. the three initiatives here, healthcare and payment come under one umbrella, we've removed and eliminated that frictional costs of insurance versus provider organizations and led to a much more efficient healthcare system. Thus, organizational strategy now has to take into account some transition in payment and start thinking about these 7 rows to maximize that payment system, but position for the next. If anyone has any thoughts or comments, please feel free to reach out, because we just said a lot in that last 10 minutes about talking about organizational strategy. We just feel it's so critical for organizations. Most, in the 1980s and in early 90s in healthcare, organizational strategy was pretty simple, because if we did this, if we became more efficient, if we had high quality and we engaged our patients, we could be successful. Because of the transition in payment now, it unleashes all of these 6 additional initiatives that have to be taken into account. Here's an advertisement for the next session. John Downs, our colleague, who's a great speaker, he's going to be looking at using market information, insights to drive rural hospital performance, market share, how to look at market share, what to do with market share. I promise you, this presentation, this is only about a 60-minute talk, so you don't have to listen to him talk as long as you have to listen to me talk. But that's next Thursday at 10 a.m. Eastern time, and I promise you it'll be good. Now we're going to dive down into kind of the operations when we show up at a hospital, and we start interviewing folks. What we're looking for essentially are responses to these bullets right here. And where there's a divergence from what we consider best practices, it highlights an opportunity. And so one of the first and the most important is emergency department admission rates. We like to tell hospitals that your emergency department admission rate, now this includes admissions to observation and acute, should be between 10 and 12%. And for rural hospitals, and we're not talking about the urban medical centers or community hospitals. We see 10 to 12% is kind of best practice within our rural hospitals. We like to look at this ED admission rate as an organizational key performance indicator that we should be talking about it, we should be managing it. And if we're not at that level, are we having the data from our emergency department physician company or our own emergency room physicians? Are we sitting down with them once a month, reviewing each of the individual providers and where they are relative to this 10 to 12%? I also would say that there's nuances. I mean, if there's urgent care availability or significant access to primary care, I would expect this numbers up to the higher range of that 12%. That 12%. If there isn't any urgent care available and people are getting primary care or less than emergency room visit level care in the emergency room, then it may be on the 10% or even lower. But this is the general range. And if we don't see this, we start asking questions and then essentially look for opportunities. What could we be doing differently? Make sure we ensure all patients are transferred away to other hospitals, come back, especially for our post-acute care services, our swing bed services. Proactively define a care spectrum. I really like this idea. I've seen hospitals that have done this. We did a project with the New York Critical Access Hospitals a couple of years ago, where several of the hospitals proactively sat down with the med staff, nursing, they're hospitalists, they're ER physicians, therapists, and said, yeah, gosh, why does it jump like that? And said, okay, what are the patients we're comfortable caring with on an inpatient basis? And proactively define those set of services that we feel comfortable with. And when they did that, there was about a 20% bump in inpatient acute admissions. Often telehospitalists or e-hospitalist programs, where some programs a nurse practitioner can act as a hospitalist with backup from telehealth coverage. Great opportunity that we're increasingly seeing now, especially post-pandemic. Uh, the Many hospitals are discontinuing the old ICU and transitioning that into the med surg unit as high observation. Any new critical access hospitals that we're seeing, really there's a high observation area immediately adjacent to the nurses station. Uh, Often what folks don't think about is that, especially a critical access hospital that has a relatively high swing bed census, your med surge cost center is much higher cost based because your swing bed comes in at 100% cost based. So on average, if you're 70% acute on the med surge and 70% Medicare cost based on the ICU, and you're having a decent swing bed in your med surge unit, what would happen is your aggregate cost-based payer mix in med surge increases from 70% to 85%. The extent you roll the ICU in there, there'll be immediate 10% uptick in cost-based reimbursement because you're rolling ICU costs into the med surge, which is a higher cost-based unit. So something to think about. Interqual criteria, making sure that we have a resource to justify our inpatient admissions, especially now, obviously with the Medicare Advantage plan penetration and they're being very challenging around admissions. Hourly rounding and bedside handoff, tracking patient ratio against industry standards, but not taking that too far. I had a hospital in New York that consultants came in and suggested that every 4 hours the inpatient unit had to essentially prepare labor variance reports every 4 hours, and which to me is goes way beyond what we should be looking at here. Because obviously, if we discharge 2 patients, we aren't going to have a nurse go home. We do that too many times, and we don't have a nursing staff. So, I think, maybe quarterly looking to make sure that we tend to look at a nurse ratio of about 12 paid hours per patient day from a nursing perspective. Are we there once checking that once a quarter? What we're seeing now, and in some states much more severe than others, is the observation as a percent of acute patient days is going higher and higher and higher. Doing some work in Louisiana in which that number is 75–80% observation relative to acute, obviously driven by the Medicare Advantage plans. We generally like to say, we like to target observation days. It'll be between 20 and 30% of acute days. And if they're not there, like really push and say, hey, do we just have a default observation within our emergency room? Because our emergency room physicians and hospitals have been beaten up so badly by the Medicare Advantage plans that we just have default observation. That puts undue hardship on the patients, the Medicare patients that have higher copay in our critical access hospitals, and obviously it reduces payment. And so let's make sure that we if we're above this range, understand why and see what we can do and make sure that we don't have default observation. Swing bed is an incredible opportunity. I find it one of the most manageable service lines within our rural hospitals. You shine a strategic spotlight on swing bed, it grows. The soon as you take that strategic spotlight or importance off of it, it shrinks. And so the key is to continue to put, kind of strategic emphasis on our swing bed program. we like to say that given your service area, the potential for swing beds is around an average daily census of 3 per 10,000 population, your service area population. Great opportunity for everybody on this call to go check, see where is your swing bed program relative to this, to your service area population. What we like to see is really proactive outreach around swing bed, meeting with case managers from regional health systems in which many of our surgeries are going. Really creating a marketing plan, actively engage area hospitals for swing bed opportunities. Many rural hospitals urban hospitals are looking to decant volume. I just had this conversation in Tennessee a couple of weeks ago with a health system that said, we're full, we can't get any acute patients in, and they had this health system happened to have a couple critical access hospitals in their network. And so the conversation with how can we decant some of the acute stays going on through discharge, their post-acute care to the critical access hospitals. Educate the provider on the benefits of cost-based reimbursement and how swing bed services are essentially 100% cost-based reimbursed. A lot of people will push back on that comment because Medicare Advantage, they'll say, is not cost-based reimbursed. I disagree with that statement. I believe Medicare Advantage plans pay critical access hospitals on a cost basis. Last year's cost, but it continues to be on a cost basis. And I would argue that we would advocate for both Title 18 Medicare swing bed and Medicare Advantage equally. We just have to manage the heck out of the denials and the denials because that's where we get ourselves in trouble. Ensure swing bed is a priority with staff, case management staff, and physician providers. This gets back to the comment that I said, this is one of the most manageable service lines within our rural hospitals and our critical access hospitals. If we continue to place a priority on that from a senior leadership perspective, you will continue to see either growth or reasonable volumes relative to this benchmark of 3 patients per 10,000 population. The other area that I get a lot of kind of conversation around is non-Medicare, Medicare Advantage swing bed providing services to the Medicaid population or Blue Cross Blue Shield. And what I just want to share is that the calculus for determining reimbursement for non-Medicare, Medicare Advantage swing beds is very different than the calculus for Medicare and Medicare Advantage swing bed. And what I mean by this is there's an imputed cost of providing these services to, say, a Blue Cross rehab patient. If you could negotiate a $600 rate with Blue Cross Blue Shield, the imputed cost that is carved out of your inpatient bucket is the statewide nursing home rate, anywhere from $150 to $350. Thus, if you could negotiate a $600 rate, if the imputed cost is $300, you have an opportunity to create a profit on these non-Medicare / Medicare Advantage swing bed days. Those days, those 10 Blue Cross days are not part of your Medicare rate per day. They are carved out. And again, the only cost that comes out is a statewide nursing home rate times those 10 days. If you don't understand that, send me an email and I'll show you how that works. But it's definitely many folks don't understand that dynamic. Emergency room. We talked a little bit about this earlier. Urgent care. Do we have urgent care services? I've had many hospitals say, "Hey, we don't want to offer urgent care because it'll cannibalize our emergency room." And what I've found is in hospitals that have opened up urgent care, there is some, I hit a hospital in Tennessee. They opened urgent care in 2 years. Their urgent care volume was 10,000 visits. Their emergency room business went from 13,000 to 11,000 visits. So correct, there was some cannibalization, but not nearly the cannibalization that that they would have thought. And in other words, what was happening in the past is either people that wanted to seek out urgent care didn't want to go to the emergency room because of the perceived cost or wait times or anything like that. We are now capturing those and continuing to maintain reasonably high emergency room volume. Are there other opportunities to manage demand for non-emergency care? Urgent care clinic to include primary care services. Often I see walk-in convenient care as part of rural health clinics within our critical access hospitals. Especially if we can roll those into our grandfathered rural health clinics. Is there an opportunity for redirect program? In other words, this is often when hospitals are incurring significant bad debt through their emergency room. Is there an opportunity, and a lot of people argue with me on this, is that a patient has come in, have full medical screening exam, deemed non-urgent. That person then can be referred over to the urgent care center or said, hey, you've been fully screened. In accordance with EMTALA, you've deemed not urgent. If you want to be seen here in the emergency room, you got to have $100 copay or down payment or something along those lines. So there are opportunities around ER emergency department redirect programs. Having signage and urgent care capabilities around, all of these are opportunities. Work with the medical staff and systems to appropriateness of transfers and often what we like to see is transfers in our rural hospitals to be no more than 6% and generally in a range of between 4 and 6%. So the percent of emergency room visits that result in a transfer somewhere between 4 and 6%. Now, again, if you have urgent care capacity in town, it'll lean towards the higher end of that range, may even exceed that range because you're caring for acuter patients in your emergency room. But that's generally what we like to have hospitals review their transfers, review all of their transfers on a monthly basis and make sure that we identify opportunities for keeping patients in our hospital. One of the third bucket of success for rural hospitals was around performance measurement. There are all types of performance measurement opportunities within the emergency room because it does run such high volume. And emergency room standby time. I mean, Wade will talk about this in the cost report presentation next week. But this is one of those areas that just the last cost report I looked at yesterday. The average professional time per emergency room visit was 52 minutes. I generally flag anything over 25 minutes and say it's probably unreasonable and you could be doing a better time tracking emergency department standby time. So that one is one that I find errs probably 50 to 60% of the time. Lean process to reduce ER throughput. I worked with a hospital a couple of years ago that they were running about 170 minutes of throughput time in the emergency department. They did a lean study and they found out areas of waste. One of the areas of waste was they were sending lab tests on a stat basis to the lab. The lab, trying to be efficient, was waiting to batch those with other tests. And so there was an additional 20 to 25 minutes of wasted time in the emergency department just because of this. But having a lean process, running a lean process in the emergency department is a great opportunity, especially if your lengths of stay and your throughput time, kind of exceed that 120 minutes. Have ED caps measures, track KPIs, ED admissions as a percent of ED visits, as we talked about, transfers, door to doc. All of these quality measures are all incredible opportunities around measurement within the emergency room. Some of the clinical departments. Here's another just incredible opportunity that we've found. And it's we're in the baseball season this time of year right now with October baseball. The analogy I like to use is department managers. 80 to 90% of department managers are generally catchers. They sit behind the plate. If the pitch is wild, they'll point to the pitcher and say, "Pitcher, it was your fault." In other words, in hospitals, they'll point to the doctor and say, "We didn't get any referrals." Versus the pitching department managers, the true pitchers are out there. The Nolan Ryans throwing the 100 mile an hour fastball, but fastballs at the chin. These are the ones that the physical therapy department director that's out, at the running the 5K walks and runs, and having the health fairs, and having patients come in over the lunch hour, or early in the morning or after hours to be seen. And generally, when you have a pitcher is your department manager, you're seeing growth in volume. And you could almost, just when we tend to track volume over a 5 or 6 year period of time for all the departments, before you even sit down with a department manager, you almost know which ones are the pitchers versus the catchers, because the catchers volume is pretty much stagnant. And what the challenge I ask of all of you is to say, if we could transition from having one pitcher in our departments to having 4 department managers who were pitching from catching, what impact would that have on our organization? Going back to economics, right? The contribution margin, incremental volume at 93% contribution margin. Incremental volume is the keys to the kingdom. Outreach to area providers to build awareness of service offerings, making sure that all the physicians are aware of the services we have. If we brought in new services, or one of our techs have gone to school to learn a new skill, are we sharing that with the medical staff? Don't assume they know everything. Man, you go back. There's a lot more to talk about on that slide. Promote your services. Have updated equipment. The last thing we want to have is one of our members of our medical staff refer their patients to a 30-year-old radiology equipment. Let's keep that up to date. Track referrals. Often this is a recommendation by us, that managers ought to know where the referrals are coming from. And by tracking referrals and measuring them to see, is there variation? This physician's referrals were down. Oh, they were on vacation last week. Or, oh, well, they're up. Maybe something's going on here. We need to talk to them about. ROI analysis and upgrading equipment. Strategic pricing to make sure we're competitive, especially on lab services. I've seen hospitals have 2 separate labs fee schedules, one for wholesalers, i.e. their physicians, one for retail. And you definitely want to clear that with your in-house or your legal folks, but having separate LEFA so that when your physicians are referring their patients to your lab, it's not looking badly upon them. Contribution margin, pharmacy. This is one we're actually going to have a whole boot camp on the 340B program. Generally, what we like to think is that for every 10,000 provider-based clinic visits, we like to see the 340B net profit be between 350,000 and 450,000. That number has ticked higher to the higher range in the last couple of years because of the GLP-1 drugs that have rolled out. Obviously, with some of the games the manufacturers are playing, we've got to create opportunities to address that. But generally, if you sat down and said, we have 30,000 provider-based rural health clinic visits, I would like to see 30,000 provider-based rural health clinics generate north of 1.2 to 1.3 million in 340B net benefit. How are you guys doing on that? The staffing, obviously, I have a spreadsheet that's going to talk a little bit about staffing. What this is looking at is just how to assess department in a critical access hospital, profitability, contribution margin. This was a home health department where you can come up with revenue. A lot of this information's in the cost report. This is cost report information, salaries, non-salary expense. The cost report allocates the critical access, each of the department's expenses. If you were to look at the fully allocated costs of this home health in this example hospital, it was about 740,000 revenue on revenue of 520,000. You would think that, boy, this is losing a lot of money. We gotta tighten this up. The problem with evaluating departments on a fully allocated cost basis is that if the department were to go away, it's not likely the CEO would get fired or the CFO or all of these overhead expenses. And so to some degree, you've got to put a factor on the costs that would go away that are allocated that would go away if that department or entity would go away. And we tend to just make estimates here that essentially what we're saying here is that the overhead costs that get allocated to the department that would go away, about 150,000 versus the 270 that the cost report allocates. In this case, the home health still loses money on a contribution margin basis before the tax from operating a department in a critical access hospital. The net gain for this department is a loss of 144,000. At least you know about it, right? Then what you choose to do with it, you could say, hey, we're going to allocate mission dollars to support this because it's an important part of our organizational strategy. Or you say to the department manager, look, you got to grow services because incremental volume in your home health is going to drop 93% contribution margin to erase this 144,000. So once you have the information, then you got a strategy for what to do with it. The next area is around physician practice management. And I always like to start off with saying, do we have the right complement of providers to meet the needs of our population? In this case, what we did is over the years, there's been studies that said, give a certain population for your community. In this case, it's 19,009. The last digit here got cut off, but it's essentially 20,000 population. The studies, the way this is backed up is that there's an Excel spreadsheet that we created that said that we would expect primary care providers to serve 20,000 population based on these studies to be somewhere between 13 and 18 FTEs. This community had 12. So what becomes very clear when you look at this from this level of data, that we're short on primary care. And we're short anywhere from 1 up to 5. But we better have some type of recruitment plans in place to address this. Same thing. So this is the low, this first column is the low end of the 3 studies that have been done over the last 20 years. This is the high range. This is your count right here. And you can see that with the exception of a couple specialties, GI and rheumatology, we are short from a specialty, which then allows us to say, okay, how do we go about and fill in some of these gaps? Whether it's partial specialists, full-time recruitment, etc. One of the best practices I like to see is a hospital in Iowa, Oskaloosa, Iowa. The CEO has developed with his medical staff a 10-year recruitment plan for medical staff. So if you think about that, 10 years, if you identify every physician that will be retiring or retirement age within 10 years, and you start to recruit for that position today, it puts you back all the way into the high schools, which creates a premium on kind of job share or a job observation where you bring students in that may seek out a career in science and math, and bring them in and have them observe your surgeons or practice. This CEO, I talked to him yesterday, and he said that they right now on this list they have 94 recruits that are dotted on this 10-year list that they're keeping in contact with twice a year. Super proactive approach to maintaining your full medical staff. He also will tell you that if I have to recruit for a spot for next year, it's a system failure. It's a system failure, and so you think about that. Do you have a longer term approach for your medical staff? this is just showing the value of primary care in the future world, where if we look at the estimated patient on a panel, a primary care physician with 1,400 patients in their panel, in the future, when per capita costs are healthcare costs are $10,000, you're talking about a family physician and a nurse practitioner are worth $24 million in the future. Let's put a real priority on recruitment, retention, and alignment with primary care. As the revenue centers, as the population, as the payment system begins to evolve or inches towards this population payment evolution. As we continue on just talking about physician practice, golly, it keeps jumping on me. There's lots of opportunities. I'd like to think that, and many of you are going to scoff at this because all the literature says, boy, we should be losing, $100,000 per physician. And I don't even know what the latest number is. I don't pay attention to it. I think in rural, we have access to the rural health clinic designation with enhanced reimbursement. If we allocate the 340B benefit to our rural providers, I think we should be break even on our physicians and our providers. And so, with that said, first of all, let's catalog all our primary care providers, and to better understand primary care need, tying back to that study that we had just looked at 2 slides prior. Make sure that we're operating in the right clinic designation. I was looking at a report yesterday. Our team was on site at a hospital in the Midwest a month ago, and there were several opportunities where this hospital had clinics that were designated as freestanding clinics immediately adjacent to a rural health clinic, where they could just include them in the rural health clinic and get the enhanced grandfathered rural health clinic rate. In addition, as freestanding clinics, the visits, then the prescriptions from those visits were not eligible for 340B. If we enrolled that clinic immediately adjacent to the rural health clinic into the rural health clinic, those visits would all now be eligible for both 340B and that enhanced reimbursement. So making sure we have the right clinic designation is an opportunity. Make sure we have relationships with specialty providers. Can we get fractional presence or even telehealth consults on a fractional basis to keep access to both specialty and primary care in our communities? Compensation. I've seen compensation agreements anywhere from just straight base salaries to base salaries with incentives for visits or work RVUs, all the way to what I consider best practice incentives, where we align the physicians or our providers' interests and goals with the organizations. In this case, I'd like to see work RVUs. I like to see patient satisfaction. I like to see panel size as a measure of the payment systems of the future. Payment is going to be through panel size and the count of panel size. I had a best practice hospital, again, a hospital in the Midwest, that they were tracking on they identified an active patient. Active patients were patients seen within the last 18 months. And they had assigned every active patient to a provider. And when patients were about to fall off that active list, i.e. not being seen within 18 months, the clinics would reach out and say, hey, come on in, you're due for your physical, whatever. Because one of the organizational KPIs was active patient panels. Well, let's create an incentive for the primary care providers to be rewarded for that. Again, recognizing the organizational priorities of the future. Have annual fair market assessments with Stark rule. I mean, that's just we should just making sure we check the box on that one. Alignment with primary care. We already talked about the importance of aligning with primary care as the revenue centers of the new world. I like to think of primary care providers as Stephen Covey talks about dependent, your 5-year-old, independent, your 18-year-old, interdependent, your 26-year-old. I like to think that all of our primary care providers are fundamentally in that independent mode. And what we want to do is seek a higher, that interdependent level of relationship. And I've seen that through a three-legged stool of governance alignment, functional alignment, contractual alignment. And where are we on those? I know Mahaska Health, what they do is they have 8 paid medical director positions where the CEO talks about how we are a provider, a physician, a clinical team-led organization, completely engaging them in governance, in function, having contractual alignments, contractual arrangements with them that link up, as we just talked about, with the organizational goals. But I like to say, we should be inventorying all our primary care providers and test that level of alignment and where are the opportunities to improve that on a quarterly basis. This gets back to that third bucket of success that we talked about in the first couple of slides, measurement. I like to look at, on a quarterly basis, E&M codes, relativity. Are our providers, is it a bell-shaped curve around level 3, leaning towards level 4, which is kind of where benchmark is, or are is the bell-shaped curve over level 2, which is not anywhere near what benchmarks are today? Other opportunities, I like to have quarterly benchmarking at a minimum of our provider performance on an individual provider basis, using MGMA as a benchmark, looking at work relativity visits, units, visits, office hours, and compare to MGMA benchmark. Our providers are scientists. They want to understand where they stand relative to their peers. What a great opportunity to do that. Invest in MGMA and create the dashboards to do this. Make sure our third-party contracts are updated. This is one I'm finding more and more and more. What happened back in 2020, there was a shifting of the RVU scale away from procedure visits towards E&M, the evaluation and management, the bread and butter of rural healthcare. And what happened was the work component, so the total RVU, relative value unit, is made up of 3 pieces: the work, i.e. the physician effort, the malpractice, and the practice expense. Back in this reshifting, the work RVU, i.e. the physician piece, was increased. For example, in 992, the work was increased from like 1.3 to 1.7. It was increased by 40 points. And so what happened was the total RVU for a 99213, which was 2.11 in 2020, is now 2.73. And what's happening is most of us have not negotiated those higher rates in with our managed care and our commercial payers. So I'm still seeing $60, $70 allowed on a 99213, whereas the Medicare allowed amount, right? If you take the 2.73, which is the RVU, and you multiply it by the conversion factor around $34, Medicare is allowing in a freestanding practice, upwards to over $90. And here we are getting paid $60 from our commercial because we have not negotiated this update. An addendum to that is, when this update happened and we're paying our physicians in incentives based on work RVUs, all of these higher work RVUs were incorporated into their compensation and their reward system unless we recognize this. So we're incurring an additional expense, but we're not getting reimbursed for it. Improve access to primary care providers by allowing open slots. I was at a hospital a month and a half ago in the upper Midwest. And they, every day, all of their providers, before they even come in, they have all of their slots full. One doctor called in sick and they went to reschedule the patients for that one doctor. This was back in August, and they could not get the patients rescheduled until October and November. What I always recommend is maintaining open slots, a couple in the morning, couple in the afternoon, that often get filled in within the first hour in the of the practice. So making sure we have access to primary care. Quality and performance. What I can really say here is that is that think about quality as a strategic driver of the future. And right now, it's the perceived game of quality measurement, which is what we call quality. In time, it will become more and more about outcomes. But right now, the game of quality measurement is how we are recognized for quality. So let's recognize and say, hey, having the best quality scores from an HCAHPS core measures, the game of quality measurement, for anyone in our region or within 100 miles, let's set that as a goal. Update the board medical staff, engage the board and medical staff on this. Multidisciplinary quality committee that meets on a monthly basis. Often I see quality committees that meet on a quarterly basis, and those often have their quality metrics, their publicly reported quality metrics, substandard relative to those that meet on a more frequent basis. Partner with medical staff, have medical staff be part of this. One of the biggest misses that I see in rural hospitals is often the hospital we're working with is the best hospital within a 100-mile radius based on their comprehensive HCAHPS scores. But it's the best kept secret in town. If that's the case, first of all, let's share that internally so that housekeeping and dietary and everyone in the organization and all your patients that come in see that we are this great from a quality, the game of quality measurement perspective. But also that then we can start, once we have internal, let's get that message external and really promote ourselves and use it as this strategic driver of volume. Yeah, report on public measures to increase accountability, to compete regionally on quality scores. Exactly. Participation and MBQIP, if you're a critical access hospital, convene patient family advisory council with community member participation. Share post metrics with all staff and utilize performance to drive improvement across the organization. I had a hospital in Missouri that I was just talking to the CEO in Kansas City last week, and he was saying how they on a monthly basis they post all their quality scores at the department level outside on whiteboards outside of each department, so people can come by. They do rounding on I think he said a monthly basis. The senior team may even be more frequently. They round they go around all the departments and have the department managers present on all of their quality initiatives and scores and outcomes. Really good stuff. Information technology. What I'd like to just say with this one is that we've let the government dictate to us what our IT strategy is. And I think about IT as the backbone and an effective EHR as the backbone of a patient-safe, financially viable healthcare organization. And if that's the case, I think that demands us to have our own strategic plan related to this significant investment around IT and how we are going to use it to how we really leverage that platform around financial sustainability and patient safe and access, right? And so, with that said, let's have our own plan. Let's really make sure that we look at IT independent, not independent, really interdependent of where the government wants us to go. Another promo here. We just a couple slides here I've got on cost reports, especially for the critical access hospitals. Wade, my colleague Wade, is going to be presenting again next Thursday around cost reports. Wade came out of a MAC. He was in a large system preparing cost reports for several years. A true expert here, and he'll be presenting next Thursday on specific opportunities for critical access hospitals. Some of the things that I look for when we go in to work with hospitals, just high level, med surg department. Did we incorporate hallways when the hallways are part of the unit itself? I generally like to see square footage greater than 300 square feet per bed. If I don't find that, I like to go tour and see what's going on. physician standby time. We already talked about this as a metric within the emergency room. And increasingly, what we're having is that hospitals are struggling to have their nurses want to participate in the standby taking or the time study process. And so organizations, technology-based organizations often will step in with automated time tracking functions as the next best case to having detailed tracking supported by your clinical team. Part A time for physicians, time studies. Often what I'll see is physicians that are in a provider-based entity clinic. There might be $5 million of physician costs, 100% of which is removed as professional time. Generally, those physicians in your clinic are participating in Part A activity, i.e. medical directorships, quality meetings. They're participating in, within the, senior leadership team within the hospital. And that time is really Part A time, and we should be time tracking that and keeping that on the cost report. Wade will touch on ratio cost to charges next week. Make sure our CDM is using pricing transparency. Amy will be talking about that at her breakout session. In nursing admin, let's only pick up the nursing admin. Let's not pick up the house supervisors. Often house supervisors are picked up in nursing admin and then allocated to all departments, several departments that the nursing admin doesn't really have responsibility for. Let's make sure that we're doing that right. For those of you with LDRPs, labor delivery recovery postpartum rooms, let's make sure that the time that the only amount of costs that are allocated to the ancillary department is the portion of time that the mom spent in labor versus the entire stay. So let's just say that your labor delivery costs overall on a fully allocated cost are $3 million. If the mom is only in active labor for 20% of that time, then only 20% of that 3 million should show up in the ancillary department. The other 80% should move up into med surg, which is your highest cost-based unit. Let's make sure that we're doing that correctly. Any of these other ones, bad debt policy. I like to see bad debt on allowable bad debt on. Did that just move on me? Yeah, it did. I like to see allowable bad debt on especially the outpatient settlement slide, the worksheet E part B, somewhere between 10 and 20% of the patient copay and deductible. Often I see that amount completely missed. If it's not between this range of 10 to 20%, immediately the question becomes, what are we doing proactively to take our, claims at our collection agency that haven't seen any activity in the last 4 months, bringing them back, deeming them uncollectible, and putting the Medicare portion of those on the cost report. So lots of opportunity, but Wade's going to dive deep into this next time. Revenue cycle. Amy, our colleague Amy, and Ryan are going to do a session on, in a couple weeks on deep dive into revenue cycle. And so stay tuned for that. I look at revenue cycle at the highest level and say there's three kind of key areas. There's three key areas that if we focus on, revenue cycle does better. The first is back to that that number 3 overall measurement. I want to see KPIs, key performance indicators, set for all important metrics within our revenue cycle. HFMA, Healthcare Financial Management, has a great listing of these measures. And what I'd like to do is I'd like to list them. I like to set a goal for each metric. I like to assign individual accountability and then trend those over time using variance from actual to target to drive weekly revenue cycle team meeting discussions. looking to take out the systemic issues that are keeping us from achieving our goals. So number one, and I think this is the most important, measurement, create the KPI measurement system. If you've outsourced revenue cycle to a third-party biller, there ought to be weekly meetings with where the outsourced revenue cycle firm presents a dashboard of all of the KPIs, and you set the KPIs. Again, go to the HFMA website, you'll find those. You set them and make sure that they're presenting in a dashboard fashion where they are, what are the goals, and what are they doing to achieve. So revenue cycle meets at least bi-weekly. I like to see this as weekly. Even those, the top performing meet on a weekly basis. The second area I like to see is that as much as we can do to move everything to the front end, that includes scheduled services that have pre-registration, calling the patient to discuss point of service cash collections and how will they be paying this, verifying insurance, all done through pre-registration functions, moving all the effort to the front end. Point of service collections, especially in your clinics. I mean, I can't imagine the dollars that are lost when we're not collecting the $20 or $30 copay in our clinics, leaving that $20 amount to be collected by your revenue cycle team. This is something, and one of the things that I see as the greatest opportunity is often our EHRs now have the opportunity to show you the N. In other words, they would say for this front office person, they should have collected $2,000 today. They collected $30. Once you have that, I had a hospital in the last 12 months that didn't know they had the ability to determine the potential copay collections in their clinics. And this was a clinic with 90,000 visits. So this was a annual visit. So this is a big clinic. And as soon as they turned on that ability to see what they were actually collecting, the collections went from 30% to 70% in 30 days. So that creating that measurement system, around that is absolutely essential. So the first thing, measurement culture. Second is move all the effort to the front end. And the third is an effective denial management. Obviously, with the Medicare Advantage plans and some of the aggressiveness of our commercial insurers, having access or a fully built denial management system is absolutely critical. Front end. So we just talked about that. Here are some bullets to talk about that front end. Prioritize point of service cash collections, especially in your physician-owned practices. Again, Amy's going to deep dive into this in a couple weeks. Implement bad debt policy that establishes claims will be deemed worthless, as we talked about, pulled back in the Medicare piece of them on the cost report. Have a quick pay discount that matches commercial discount. Yeah. So all of these things we essentially talked about on that other page. Management accounting. This is one of these incredible opportunities to engage your entire management team around the business of healthcare, and it's often overlooked. I like to see the annual budget process have the CFO and the accounting team engage department managers on both revenue and expense. Often the focus is on expense. And as we had talked about early on, if 93% of our costs are fixed or step fixed, and we're aggressively holding them responsible for fixed costs, they're not doing a lot. But if we could engage them in establishing the budget around volume revenue, we're doing something. And so let's engage them in that process. Then on a monthly basis, regular, consistent financial statements, the 15th or the 20th of every month, with required variance reporting. In absence of required variance reporting, you'll have the department managers, the pitchers that'll be interested in their numbers and really dig into them. And then the catchers will sit back and hit delete. And so let's make sure that we engage these managers. Establishing dashboards. Is there an opportunity to go beyond? I had a hospital a couple of years ago out in Nebraska. They used some of the Studer group where they assigned, each department manager had outside of their budget, they had KPIs, 4 KPIs, some around volume, some around efficiency, but they held them accountable, and then they rewarded them for performance. Um, and again, monthly budget to actual reports, all good stuff. But I look at this as the cornerstone of establishing this accountability culture through measurement within our organizations. Don't miss out on the opportunity to do this. Staffing, we look at staffing. It's never been a recommendation. If an organization has quote excess staff, there is an opportunity to grow services without adding staff. But here's an example of a hospital. I'll just kind of walk you through this one, recognizing we're running out of time here. So nursing, for the nursing unit, this is looking at volume. The hourly standard, this is the hourly standard. We've developed this at Stroudwater over years of working with rural hospitals. It's paid hours. It's not worked, it's paid. So for this hospital with 4,500 patient days, and it includes observation and swing bed and acute, the standard would be 26. They have 34. So they have excess. They have OB. In OB, there's a certain amount of minimum staffing levels, unless you can, share staff between OB and med surge. Not often easy to do. But in this case, they have excess, again, quote around access of staff around 13. What a great opportunity to grow services, swing bed program or et cetera, given the staffing that we have. So, emergency room's another one. We tend to look at about 2.75 paid hours per emergency room visit. That would equate to, on standard, to about 10.2. They're running a little higher at 14.5, not far off, but and then every other, you can see coming down here, the volume metric, and then the hourly standard that we use. But I always like to tell hospitals, we'll look at this, but it's never been a focus, because every hospital has staffing a little different. Someone might staff, case management may have a nurse in one hospital that another hospital would put in their med surg unit is in case management or nursing admin. And so you got to take some of this stuff with a grain of salt. Use it not as shooting darts, but more as shooting hand grenades. We're going to jump over this because it's really interesting, but we don't have time. Aligning, we're going to jump over this. Payment system transformation, this is moving all the way down here. And what this is saying is and I really, this bullet right here, circle this one. I want to start thinking about our community as people rather than as patients. Think about what I just said there. I want to think about our community as people rather than patients. Patients implies sick care. I want to be that practice that at 18 months of not seeing somebody, we reach out. Come on, let's get you in here for your physical, you're due. And all of these different payment systems are ways to proactively engage our community as people rather than patients. Chronic care management, transitional care management, behavioral health intervention, well child visits, healthy physicals, all are opportunities to do that. Disease management programs, consider self-insurance plan. All of these are opportunities. Proactively develop a plan to participate in population health payment systems like an ACO. I'd like to see rural hospitals tend to do well in ACOs because only 30% of the dollar of the total spend is spent in rural. In other words, you're playing with somebody else's money if you bring down costs. And then you share in that. So I really like the idea of participating in ACOs. There's lots of bullets here. I think we jumped over one. Yeah. Anyway, there's enough bullets here. You'll get all of these slides. So you can feel free to reach out on any of this stuff. And then population health. How do we start to create this blue bar here in the middle? I'm up in the top right. How do we create this? Recognizing we don't want to go too fast. We want to build some infrastructure. So first off, work with your medical staff around evidence-based protocols. Create a science, create a science around care management. If we have access to claims, either self-insured claims or ACOs, use those claims, review them on a minimum quarterly basis. One of your greatest opportunities in your self-insured plan or an ACO is to reduce outmigration. Figure out where your patients are going, start asking why, and whatever we can do to bring them in. If it's incremental volume to us, if we have to pay $10,000 if one of our self-insured employees goes downtown for a service, it costs us $10,000. If we can keep that patient in our hospital, we get paid the $10,000. So there's revenue to offset the self-insured claim expense. Our true cost is $1,000, i.e. the variable cost of that patient admission. So we just saved $9,000. Let's better understand how that plays out, that contribution margin. Patient-centered medical home, team-based care are opportunities to build infrastructure without creating health too quickly. So questions, but before I get to, we're going to run out of time here, but here are the dates and times for each of the next 5 boot camps. I think every single one of these boot camps, here's the first 3. And then as we move out, the 340B program is October 23rd. The revenue cycle is on October 30th, as we just talked about. But, I think every single one of these boot camps is going to build on what we just talked about today and hopefully add value to you as we are dealing with some of the uncertainty that came down the pike. So we're at the end of this hour, 30 minutes that I suggested. That was a lot of talking. I imagine half of you are asleep or got up and left. But any thoughts or comments that we could answer would be great. Okay, recognizing that there was no questions or comments, we're going to give you back 30 minutes of your day and wish everyone a beautiful weekend up here in the Northeast. It's going to be a gorgeous, gorgeous weekend in the 80 degrees. And so appreciate y'all listening in, and TGIF, have a great weekend. Thank you.